But today gives me great pleasure to introduce Dr. Jeffrey Brenner. His title of his talk is above, Hotspotting Innovative Approaches to Caring for the Very Ill. He is the Executive Director of the Camden Coalition of Healthcare Providers. Many of you know a lot about his work. In fact, I should tell you that the suggestion of having you speak really came largely from our students because they follow your work and they're very excited about the work that you do. I'm not going to spend a lot of time introducing you and going through bios because people like to hear from you and not from me. So I will turn it over to Dr. Brenner and let you tell us about what you were up to in Camden. Thank you.
Great. Thank you so much. So thank you for the invitation to come speak tonight. I really appreciate it. So I'm a family doctor. I've been working in Camden, New Jersey for about 15 years, mostly as a frontline provider, seeing kids, adults, and delivering babies. And for the last 12 years, building a citywide coalition. The idea that if you round up all the stakeholders, the alphabet soup of healthcare, that you could actually make a difference in how healthcare is delivered. So the Camden Coalition of Health Providers was formed originally as the Health Provider Breakfast Group. It was a group of very grumpy primary care providers working in small offices in the city of Camden who came together to think about how we could deliver care differently. We're now about 50 staff, an annual budget of about $5 million, and our vision is to be the first city in the country to bend the cost curve and improve quality. And our mission is very healthcare focused. So I'm not going to focus on clean air, not focused on clean water, not focused on obesity, primary prevention. I'm focused on how to fix healthcare, and not healthcare for everyone. I'm really focused on tertiary prevention. So you remember primary prevention's keeping healthy people healthy, secondary is keeping people with chronic illness healthy, tertiary is keeping people who've had a terrible thing happen to them, getting them healthy again. So those are people with heart attacks and strokes and have had catastrophic things. So that's by and large our focus in the city of Camden is to focus on those patients. So I want to give you a little introduction to the city, first of all. So we get funding from the Merck Corporation and Navident, are our only for-profit entities, neither of which I'll be selling tonight. So the city of Camden is 79,000 people. It's 9 square miles. It's the first, second, or third poorest city in the country, first, second, or third most dangerous city in the country. And we have a lot of stuff that no one else wants. So we have a lot of housing that people don't want to live in, so lots of abandoned housing. And one of the reasons that housing is abandoned is around on the other side of the block. This is in South Camden. It's a Superfund treatment site. So much like Philadelphia and many poor cities, we have what are called brownfields, which are contaminated areas. And this was radioactive contamination that leached into the basements of these people's homes. And about a block away is a sewage treatment plant where if you flush a toilet anywhere in Camden County, it ends up in an open sewage treatment plant in the same census tract. If you throw away trash anywhere in Camden County, it ends up in an incinerator, which is another further block away. It has a lot of scrap metal plants, and it also has, we end up with all the people that no one else wants as well. So we end up with the mentally ill, the drug addicted, recently released prisoners, sex offenders, and in fact, 9 counties around will often send people into Camden for social services. The city just doesn't have the wherewithal to even begin dealing with all of this. But it turns out to be a great place to fix healthcare. So anyone want to guess why? Students only. Yeah. What's that? So you're absolutely right. So it turns out that it's a lot easier to innovate when there's nothing else in the way. So we actually don't have a health department. 25 years ago, they closed the health department, and they all of the legal requirements that the health department meets were turned over to the county. So the county health department fulfills the city's health department. There is no infrastructure in the city of Camden. Camden city government has shrunk and shrunk and shrunk. They actually laid off the entire police department. That was the biggest part of city government. That's gone as well. So it turns out that it's easier to do new things when there's no infrastructure in the way. So what else? Anyone else? Any other ideas? Yeah. So certainly having an important societal need. It's a very poor city with overwhelming problems. Go where the problems are really complicated and really intense. That's in some ways that's a good place to be, right? What else? Yeah. We have a lot of hospitals in our county. So we have 3 emergency rooms. 2 hospitals. We've got about 20 primary care locations. And probably the most important reason that Camden's a great place to do this work is that no one's fighting me over more market share. And that's probably one of the most important points I'll make tonight, which is all of these hospitals are suburban facing. If I were in Cherry Hill, or I was in Society Hill, and I was delivering better care at lower cost and eliminating the need for people to go to the hospital, they would have taken my legs out from under me. So the only reason I've been allowed to get away with what I've gotten away with is that I'm delivering better care at lower cost to mentally ill, drug addicted, chronically ill patients that none of them want more market share of. So that's a really important piece of the story. We have lots of old ruins. This is a Carnegie Library with a tree growing up through it, so it's like the tree of knowledge. Lots of beautiful old buildings. So I want to talk a little bit about hot spotting and superutilizers. So there's one of the problems I think in healthcare and in public health is that we have some non-specific language about what it is I do. Like we have this word care management, and it's kind of a meaningless word. So care management can be a nurse in a cubicle calling a homeless person with no phone, or it could be a program like ours, which is boots on the ground, people in the streets banging on doors. When you have a word that's used for activities that are that disparate, then the words just really become meaningless. So some of the words that we've been using, hotspotting is a word that came out of policing in New York, out of the work that Bratton had done. But hotspotting is really an analysis of outliers. So in epidemiology and biostats, we often get really interested in the average and the means and the medians. But, and we often cut off the outliers. They kind of mess up the data set. They're a non-linear part of the data set. And our belief in Camden is that the most valuable part of the data set, if you want to learn how the world really works, don't study averages and means. If you want to know about a complex adaptive system, a messy nonlinear system, you want to spend time with the outliers. Because the outliers will actually tell you a lot more about the basic underlying properties of the system. And that's absolutely been the true for healthcare outliers. They are an incredible story. Each patient is a story of unbelievable fragmentation, failure of the system. So the other word that we've been using a lot are superutilizers. So superutilizers are the long, messy tail of data, the big non-linear tail of outliers. And hotspotting is finding them in a very data-driven way and then delivering specific services to them. So lest you think that my talk today is about poverty, this is the brain of a middle-class woman with a master's degree who, in a highly integrated delivery system with 5 emergency rooms connected by Epic, which is a state-of-the-art electronic health record system, for which you all, the taxpayers in the room, need an incentive payment of millions and millions and millions of dollars for this hospital to adopt. This Epic system has a tab that you can click on to find all of the radiological results, just with a click of a button. So, you know, we always talk about how important it is to have health IT and how to integrate information in healthcare. So this is a totally integrated delivery system. So this woman went for 102 emergency room visits, 54 admissions, had 147 CAT scans, and 73 CAT scans of the head. And in case you can't read CAT scans, that's a normal CAT scan, as were all 73 of the CAT scans. So it turned out that she had severe anxiety and was going over and over and over to the emergency room and being scanned over and over. So a group of family medicine residents who decided that they were going to go out and hotspot found this patient, began to work with her, visited her at home, got to know her, and got a psychologist involved. And it turned out her anxiety was very amenable to treatment. She stopped going to the emergency room. So this is not the story of poverty. This is the story of the American healthcare system. And it's not a story of failure. It's actually a story of wild success. The biomedical model has been wildly successful in the last 50 years. We can pull people back from the brink of death. We can separate Siamese twins. We can transplant hearts and lungs. I know what you learn in public health. You learn the biomedical model didn't do anything. It was all clean air, clean water, and vaccinations. But when your parent, grandparent has a heart attack, it's that angioplasty that does rescue them. So, the biomedical model has attracted money, power, and influence in American society because it does incredible things for people. But we actually have too much of a good thing, because the downside of all this has really been unbelievable complexity, that we can do so many things to people that we don't know who to do it for, when to do it, how to do it, and we don't coordinate any of this. So we have a really hard problem ahead of us, which is how to untangle the complexity we've created. So I want to give you some other examples of the kind of people we see in Camden. This is a 55-year-old male admitted for GI bleed and shortness of breath. It's a dual-eligible patient. So dual eligibles are poor, elderly, disabled people who have both Medicaid and Medicare. They're the most expensive subgroup in America. This patient lives in a high-rise apartment. In 6 months, had 9 emergency room visits and 6 inpatient visits. Patient's on 12 medications a day, has end-stage renal disease, kidney cancer, hepatitis B, high blood pressure, high cholesterol, blockages in his arteries, asthma, glaucoma, sleep apnea, and severe back pain. This is a care map of this patient. So the patient's in the middle, and the patient went out to hospital number 1, got readmitted, went out from hospital number 1 to subacute rehab, got readmitted to hospital number 2. We had to interact with home nursing, PT and OT, transport, meals, durable medical goods, dialysis, nephrology, transplant. Primary care provider had to coordinate ophthalmology, pain management, GI, cardiology, urology, oncology, and surgery. So anyone in the room overwhelmed by this? So that's success, right? I mean, it's amazing we can even do that many things to people. So the problem we have in America is that slide is the entire long-term federal debt. So if you look at the long-term federal debt over the next 50 years, the bulk of the long-term federal debt is healthcare. The number one reason in America for bankruptcy is healthcare. The reason the middle class have not gotten a pay increase, we think, is because so much of the money has gone into healthcare. The out-of-pocket payments that your parents and some of you are making, the deduction out of your checks, the co-pays, deductibles, that's it. It's all right there. So that's what you're buying. That's what you're paying for. And we're really far away from solving that problem. The Affordable Care Act is a toe in the water. It's the beginning of making changes to solve this problem. But we have about 20 or 30 years to figure this out. So for many of the young people in the room, you guys need to be the ones that figure this out. We are so far away from figuring this out because none of those circles know how to play nice. Doctors don't know how to work with their colleagues. They don't know how to communicate. They don't know how to work in teams. They're used to telling other people what to do. They're used to calling people like this non-compliant, non-adherent. We don't move data around in a way that makes this easy to solve. We don't have all the workforce to even begin doing this, all the different true job descriptions you'd need to solve this. And we don't have the payment model to solve this. Even if I pull the payment lever tomorrow and change how we pay for healthcare, it would still take another 20 years to retrain the 1 million doctors that we have in America. So we have a long way to go to solve this. These are the crazy piles of medicines that you find in people's homes. So this is a visualization of this patient's care. This is in Excel. This is time along the bottom. In the pink side is 1 year of pre-enrollment. The blue side is post-enrollment. This patient had $300,000 in charges, had $59,000 in payments to Cooper, Lords, and Virtua for his care over a 1 year period pre-enrollment, 24 days in the hospital and 2 emergency room visits. Each red line is an inpatient visit. The height of the red line is the length of stay, and the blue tick over there is an ER visit. So the patient stopped going to the emergency room, and let me introduce you to him. His name is Glenn. He passed away from his kidney cancer, but he gave us permission to share his story. On the left is Dr. Knowles, a primary care provider, and in the middle is the real hero of the story, is Corinne, who's an AmeriCorps volunteer, who works as a Teach for America volunteer with Teach for America, a health coach in Camden with us. So it's like Teach for America. She spends a year with us, and we did a lot of training. And on the right is Jason Torrey, who's a nurse. And this patient, Glenn, didn't really like to be in the hospital, but he was completely and totally overwhelmed by the slide that I showed you earlier, as would be many of you here in this room. And he really just needed someone to support him emotionally, to navigate through the system, and to work with him to coordinate all this. Another example is a 52-year-old woman, Spanish-speaking, admitted for shortness of breath, lives with a family. In 6 months, had 6 inpatient visits. She's ventilator dependent, has a tracheostomy, a hole in her neck, and severe COPD, which is a form of lung disease. 1 year pre-enrollment, she had $745,000 in hospital bills from Cooper, Lords, and Virtua. She had $95,000 in payments made to Cooper, Lords, and Virtua for the hospital side of her care. She had 55 inpatient days, 1 ER visit. She had a 6-day stay a week later, a 4-day stay, a week later, a 7-day stay, then a 10-day stay, an 11-day stay, on and on. She stopped going back after we worked with her, and this is Lillian Perez. Lillian's there with her graduation diploma. She spent 90 days with us, and Ashwin on the left is my secret weapon. So Ashwin was also an AmeriCorps volunteer last year with us, just out of college, and he's now in med school. So I think my only hope of fixing my colleagues may be to just create a whole new generation of professionals. In the middle is Jason, and on the right is Corinne again. It turned out that Lillian, once again, also didn't like being in the hospital. And Lillian's family was terrified of the ventilator. And we got her into an LTAC unit where they did enough training with the family so they actually understood how to manage the ventilator. And then we went with her to her primary care appointments and specialty appointments so that they would work as a team and be on the same page about how to manage her care. So the way our intervention works is we run a health information exchange. We get real-time demographics, labs, radiology results, hospital discharge summaries, streaming into a data warehouse. It's accessible to any provider in the city through a web-based system. We export out of that the list of everyone who's been hospitalized in the city every day. We then log into the EHR system of both hospitals and do a pre-enrollment, a triage process. Then we go to the bedside. Then we go to the patient's house within 72 hours. We go to their home, within 72 hours, with them to their primary care appointment within 7 days, with them to their specialty appointments, help them fill out benefit applications and coordinate their care. So the Camden Coalition is a membership organization, and my members are 3 hospitals that hate one another, 2 federally qualified health centers that don't like one another, a bunch of small practices, and then the rest of the alphabet soup: behavioral health, addiction, long-term care. And because we're a membership organization, we re-elect our board, re-elect our executive committee, and re-elect our officers every year. And that's a lot of work to make work. That's a very complicated governance model. It would have been much easier for me to just recruit a professional board of experts who could help run this. But that board is really an engagement model. This is community organizing in my community. This is the painstaking, hard, painful work of collaboration and coalition building that you learn about in public health, that I learned about when I studied public health as well. So I hope that you see built into this work a lot of what I learned in my public health training. Our belief at this point is that you need 3 things to fix anything in healthcare. You need engagement, and that's patient engagement, provider engagement, institutional and stakeholder engagement. You need clinical redesign, and this means systems engineering, process redesign. This is box by box redefining workflows and how people move around within the system. And you need data, but you need data in very different ways that I'm going to show you in a second. So for the data wonks in the room, I want to talk to you, do a little bit of data since we're in public health school. Our belief at this point is the way healthcare is used the way data is used in healthcare is all wrong. We often segment data sets by disease. And it turns out that doesn't really make any sense. It's not the right bucket. So if you take a severe diabetic and you take a well-controlled diabetic, they actually have almost nothing in common with one another. They have different ethnography, different psychology, different sociology. They even have different metabolism. They have different biology. If you take a severe heart failure patient and a well-controlled heart failure, same, different family structure, different ethnography. If you take the severe version of all these different diseases, they actually look a lot like one another. So what we've done, though, is we've grouped these patients by disease in these very narrow biomedical categories. So they all go see an endocrinologist. They're all in the ICD-9 system. They're 250.0. But they actually don't make sense. If you're going to build an intervention, those people are completely different from one another, and they don't really bucket out. In fact, the comorbidities, the patients that share the complex version of all these illnesses, are where the greatest challenges emerge. So let me give you a different way of segmenting the data. This is called a typology. So this is a crosstab. This is all of the data from 1 year in the city of Camden, broken out by emergency room visits and inpatient visits. So the way you would read this is way, way over here. 62 people had 5 or more inpatient visits and 10 or more emergency room visits. They're a very interesting group. So that means they got treated and released from the emergency room 10 times or more. Every time you go to the emergency room, it's like a roll of the dice. If they're busy or you frighten them, they don't have time to sort it out. They just send you upstairs. So they got treated and released 10 times in a year, but 5 or more times they got admitted. So whatever was going on rose to the threshold 5 or more times of admission. Those are very sick patients. The ethnography, the demographics of those patients, they're older, they've got a lot of comorbidities, they have mental illness, they have a lot of family instability and chaos in their lives. Over here, 339 people in the city of Camden had 10 or more emergency room visits in 1 year, but they never got admitted. That's fascinating. That means they went over and over and over, never scared the ER doc enough to get sent upstairs. They turned out to be younger. They are more drug addicted with pain and personality disorders. They're a very different category of people. If you were going to build an intervention, the intervention for these people would be very different than the intervention for those people. But lots of you would write a grant that would say, I want to raise money to focus on ER and hospital utilization. And then you kind of non-specifically start picking up random people in all these buckets without a clear understanding of how different all these buckets are. And it's because it's very hard to get this kind of data to be able to segment the marketplace into the right buckets and then think about very specifically in a targeted way what you're doing. So a lot of places do what are called ER diversion programs, where they hire the warmest, fuzziest social worker you've ever met, and they put them in the emergency room. And I'm sorry, I hope I didn't offend you. And statistically, if you were that social worker, what are you going to spend all day doing? Who are you focusing on? It's just a roll of the dice. You're going to end up dealing with the 26,000 people who went once or the 13,000 people who went twice. So an emergency room is so chaotic that you can't be targeted or focused often. So you'll end up spending this really valuable resource on the wrong thing. So let's pretend like you've been hired in your first job, and you got a job in a hospital or a health plan, and they want you to build a program. You're a newly minted public health practitioner. We want you to build us a project. So over here, these are the inpatient overutilizers. There's 500 of these patients in the city of Camden. They're 1% of the population of users of the hospital and emergency room. They had 2,000 inpatient visits, 4,000 emergency room visits. They had $10 million in payments for their care, which is 20% of total spend for the inpatient side, and $1.7 million for their ED payments. So if I told you, build me a program that would have 10% savings on $1 million baseline for 500 people, all of you could sit down and chart out for me a staffing model that would cost $1 million and target 500 people. You can get your head around that. So that's how you would build the project. Over here, if they said build me a program for ER overutilizers, it'd be 5,000 patients, which is 9% of the population. They had 28,000 emergency room visits. It's $11 million in spend. It's 27% of total spend. So now I'm going to give you $1 million, but now I need you to build me a program for $1 million to touch 5,000 patients. That's a completely different program, right? That's a very different program design. That's actually a much harder program to design. And as soon as you get up to those kind of numbers, now there's no way your team can touch 5,000 people. You're going to have to sort through and be much, much more selective. How are you going to pick and choose? If you just hire the warmest and fuzziest, kindest team anyone's ever seen and throw them into the mess, what do you think is going to happen? Are they going to work with the hard patients or the easy patients? So it turns out what happens in public health all the time when we build interventions is that we start sliding down the continuum to the easy clients, because often the way that we count effectiveness in our project is clicks. How many people did you enroll? Well, who's the easiest folks to enroll? The 4 to 5 or the 10 plus patients? Who's going to return your phone call? Who's going to smile at you when you walk in the room? Who's going to collaborate and cooperate with you? How much savings do you actually think you're going to get off of these folks? Maybe not that much, because they actually didn't cost that much. Emergency room visits are maybe $300-400 a pop. So 3 times 4, you got to save a lot of these patients before you're going to make any headway. So, we don't use this data very well to make strategic decisions in population health and public health, because we often don't have the data. So what we do is run around and enroll people in our programs with very non-specific criteria about what we're doing. This is a segmentation of the data based on geography. So this is a map of the city of Camden. It's 9 square miles. And this is 5 years of the billing data from Cooper, Lords, and Virtua laid on top of one another, with asking a simple question, which is, do expensive people live together in congregated housing? So 6% of the census blocks is 10% of the landmass, 18% of the patients, 27% of the visits, and 37% of the payments for the hospital and emergency room care. The 2 most expensive buildings in the city, Northgate 2, had 600 patients with 12 million in receipts, and Abigail House had 300 patients with 15 million in receipts. The building at the top is publicly subsidized housing for dual eligibles. The building at the bottom is a nursing home and subacute rehab. So I want to tell you another public health story. This is my favorite public health story. So Northgate 2, I said to my staff a couple years ago, we found it. This is it. This is the hot spot in Camden. This is where all the costs are, right here. If we bend the cost curve in this building, then maybe we could actually do it at the city level. So I said, throw everything in the kitchen sink. I don't care how much money we spend. We're going to fix this one building. So one of our partners, as a result of a lot of discussions, opened up a 2-exam room primary care office on the first floor. It's very logical. We had collected a lot of stories about how hard it was for patients to get to their doctor. So one of the things we did is team up with a church group called Camden Churches Organized for People and collect lots of stories about what was going on in the building. So the other thing I said to my staff is, they have a beautiful rec room down on the first floor. I'm like, let's do lots of cool programming on the first floor. Let's do our Stanford chronic disease model. So we got that going. Then we started doing diabetic education. And then I said, think crazy. Let's spend lots of money. Let's do something really good here. So we did art therapy. We did group therapy. We did exercise, yoga. We did anything we could think of, anything my staff wanted to do, we paid for on the first floor. Then 2 years later, we got a hold of the list of everyone who lives in the building. We got the 10 years of claims data from Cooper, Lords, and Virtua, and we got 2 years worth of billing data from the primary care practice, and we connected all the data sets. So it turns out that 3/4 of the building never uses an emergency room or hospital, that all the utilization is concentrated in 1/4 of the building. So there's actually a hot spot inside of a hot spot. So what we didn't know was the denominator. So the most important thing in population health is the denominator. And what we knew was the numerator. So the hospital data set is the numerator. It's an event that's happened. What we didn't know is when an event doesn't happen, when someone doesn't go. So it turns out that only about 30 people in the building are driving all the inpatient costs. And we missed them because I didn't understand their ethnography, their sociology, their psychology, their family structure. They're isolated, they're overwhelmed, they're bedridden, they don't come out of their rooms, they don't trust. They have very different lives and ways of viewing the world. The patients that come downstairs to the first floor are more social, they're more networked, they like coming out of their apartment, they're generally healthier. So I was really on the first floor doing primary and secondary prevention. I wasn't doing tertiary prevention. I thought I was doing tertiary prevention. And the problem is that there's no ROI on primary and secondary prevention. So ROI is return on investment. And there's a special place in heaven for doing primary and secondary prevention, but there's very little business model for it. In most cases, primary prevention increases costs. In many cases, secondary prevention, if it's not done right, will actually increase cost as well. So what we were trying to do was tertiary prevention, focusing on very sick people who've had events already. And we screwed it up. And we've messed this up over and over and over because we haven't been very focused in our targeting. The other thing is that we looked at the patients who came downstairs to the primary care office, and only 100 out of the 600 patients in the building switched over because older and disabled people don't want to give up their primary care provider. Even if they can't get in, they still won't give them up because they've been going there forever. Also, the distribution of people who did come down to the health center, the 100, was an even distribution of all the bands of utilization. So I had a few high utilizers that switched over, but the vast majority of patients that switched over to the health center were basically healthy. Didn't ever go to the hospital, or rarely ever went. So what we're doing now is we're changing this intervention to be a care coordination intervention. So through the HIE feeds, I know the address of everyone. So as soon as a Northgate 2 resident lands in the hospital, I immediately know it. And we dispatch our care coordination team and help them land back in the building and coordinate all their care. So like, duh, it's not like I rolled out of bed yesterday and hadn't done care coordination, but what I've done over and over and over is had incredible data and didn't really listen to the data. And I made assumptions about what the solution was. And I didn't target correctly. I wasn't clear. What's your goal? Who's your denominator? What's your target population? What are you trying to accomplish? And how do you build a highly reliable, highly structured way of solving that problem that can be replicated? We've done mapping around the country and found similar patterns. So this is a map from Maine showing similar patterns of utilization that high-cost complex patients in Maine collect into town centers and into buildings. We've mapped suburban communities. We've mapped labor union. And over, we've seen patterns in the data set that people get collected up into buildings. So I want to end talking for a couple minutes about why saving money is so hard in healthcare. The other thing I want to mention is that I think what I do is population health. And population health isn't this field between medical care and public health. It's actually a new third and distinctly different field that's borrowing ideas from public health and borrowing ideas from engineering and from business and from psychology and sociology. And that's why it's such a hard field to create, because it's a consilient field drawing from many different disciplines. So it's in its infancy. It has 30 years of work to get the basics laid down of this new field. It has a lot of new terms to figure out and a lot of new frameworks to figure out. And it would be great if public health owned this new field. But it requires a very different framework and a very different mindset about how it's done. It requires a lot more focus on return on investment. It requires a lot more saying no on what you don't do, and a lot more focus on specific populations that you are going to focus on. So saving money in healthcare is really hard because it's a blockbuster video moment for the healthcare industry. So healthcare is the world's largest economic bubble. It's a $2.8 trillion industry that's 18% of our economy, that's floating on a sea of what we considered safe debt, hospital bonds and other kinds of debt. And it's the largest economic system in the world. We spend more than any other country on healthcare, and it's the biggest chunk of our economy. And in Philadelphia, you're at ground zero. There is no way that we need the number of academic health centers that we need to have in Philadelphia. How many gamma knives does the city of Philly need? How many open heart suites? How many angioplasty suites? How many NICUs do we need? How many hospital beds? We have way more than the population needs. We had way more 20 years ago, and we still have too many. You're going to see still mergers and consolidations in this industry. If there was an outbreak of health and well-being in Philly, our whole economic model of beds and meds would collapse on itself. So we have a really big problem that at some point we're going to have to figure out how to buy all this capacity down. And it's publicly subsidized capacity in many different ways. So there had to have been a moment in Blockbuster Video where an executive came to the leadership team and they said, people are renting videos online and they're waiting for them to come in the mail. And the executive team said something like this. Here's how I imagine the conversation going. We have internal data at Blockbuster Video that shows that our customers spend 1 hour and 15 minutes in our stores every Friday night. And they walk from aisle to aisle to aisle, arguing with their spouse about which movie to pick. Why would anyone spend 1 hour and 15 minutes every Friday night if they didn't like it? We're fine. We're a huge stock. We're a wealthy company. We own real estate all over the country. And the story of America is the story of disruption, that we aren't afraid to disrupt industries. We aren't afraid to put things out of business. There aren't any horse and buggy manufacturers around the country anymore. So the story of the last century is really incredible increases in productivity by killing the stuff that doesn't work, that doesn't add value. And at some point, if you don't add value to society, you will be put out of business. So this is really an existential moment for our friends over in the hospital industry. And they're not all going to make the pivot. Very few legacy industries, organizations manage to pivot to whole new business models. So right now they all wake up in the morning and they have maps of market share and they I've been in the meetings. Let's, are we going up or down in brains? How many hearts did we get this month? How are we doing on lungs? I mean, they're literally talking about your parents, grandparents, friends, and relatives as market share and moving that market share around. And the whole game is moving market share around. And it's not any market share. It's the high-paying market share that is based on procedures, cutting, scanning, zapping, and hospitalizing. It's not based on talking to you. So we're really far away from the business model shifting from more market share of hearts and brains to delivering high-value care every day to everyone, delivering better care at lower cost. That would flip the power hierarchies inside of institutions in very profound ways. Which brings me to the next slide. This is the other thing that will hold healthcare back. So this is the physician compensation in 2012. Over on the right is what a pediatrician makes, family medicine, $170,000 a year. Over here, orthopedist cardiologist making $400,000 a year. That's the average. In Philadelphia, orthopedists make $1 million a year. And what they do is they play all the institutions against one another. It's a form of game theory. So all the hospitals want to grab all the orthopedists up and lock them down, and they move every 3 or 4 years between the institutions. And every time they do that, they jack up their salary to the point that the institutions are almost losing money on them, but they want to hang on to them so that Penn doesn't get it, and so Jefferson doesn't get it, or Cooper. They want to lock down that market share. So the biggest problem with this kind of hierarchy is that it's really hard to tell people making $1 million a year that they might be doing something wrong and that they need to change their behavior. That's a really big problem. The other problem with hierarchy is that hierarchy is not innovative. This is really not just about money. This is about power and influence, and about how power and influence is allocated both within society and also within institutions. The doctors that have seats on the board of these institutions are not the family docs or the pediatricians. It's the rainmakers, the suite folks. Those are the folks that are up in the leadership suites that get the chief medical officer's job or that wield influence around the institution. And in very hierarchical organizations, people don't wake up in the morning and innovate. They don't change what they're doing. They just do what they're told. So flat structures are much more innovative. So as I go around the country, all of the most innovative healthcare is in the middle of nowhere. Danville, Pennsylvania, Geisinger. Who's taken a vacation to Danville, Pennsylvania? Anyone? Yay. So, if you meet the doctors at Geisinger, if you were an orthopedist that wanted to make $1 million a year, you probably didn't go to work at Geisinger. When I go to the Midwest, to Health Partners and to Fairview and these other big systems, what you find is much less doctor hierarchy. That the doctors that want lots of money, power, and influence don't go to work in these places. And as a result, those places are racing ahead. They're far more innovative. The other problem is that if this is your institution and you sign a contract, you become an ACO, or you sign a risk-sharing contract, right now these folks are your rainmakers. They're making all the money for you. Now they're your cost centers. Now you're like, stop doing unnecessary hips and knees. And then they say, well, last week I was the hero for all the unnecessary hips and knees I did. What's going on? So, and the last piece is that the only way to make that much money is to do unnecessary things to people. So let me give you some very specific examples. A very famous study looking at arthroscopy, which is a scope of the knee that your parents or grandparents may have. It's mostly done on 40 and 50-year-olds who are overweight and have wear and tear in their knee. They've got a little bit of swelling. They go into their primary care doc, eventually get to an orthopedist. They finally did a true randomized controlled trial. They put the scope in and just pulled it back out. You woke up the Band-Aid on your knee. You didn't know which group you're in, whether you had the trim job or nothing. You just pulled the scope out. You got better at the exact same rate. We do 650,000 arthroscopies a year. Medicare by law is required to pay for this. It doesn't work. If the young people in the room today, if you're skiing or you're doing soccer and you get a tear in your meniscus, it's a miracle. They will go in, they'll tack it down, and you'll heal up. But if you're 50 and 60 and you're overweight with wear and tear, trimming your meniscus is meaningless. It doesn't do anything. The reason they get better is if you take someone out of work for 12 weeks, you tell them that they're not allowed to cook and clean, they go to physical therapy 3 times a week. You'd all be healthier, every one of you in this room. So that's why they get better. So there are many, many, many examples in healthcare of us doing unnecessary things that often hurt people, that make a lot of money and don't really work. So I think I'm going to wrap up now because I want to leave some time for questions. So let me close by saying I really appreciate the chance to come and talk with all of you, and how important your public health training is, and how important the lens of public health is to fixing healthcare. Really encourage you. There are going to be a lot of jobs in population health, and there aren't enough people who know how to do any of this stuff. So, I see great opportunity for all of you in this room. So, can we take some questions?
Thank you very much. We have a mic going around. Please make sure you're talking to the mic.
Question?
There's various indices that have been devised of preventable hospitalizations or preventable emergency department visits. Have you found it useful to use those in your work?
No, and we've certainly looked at them. Billings algorithms, ambulatory care sensitive conditions, and the problem is to do that study right, you'd have to build the penultimate model of care delivery, deliver incredible care to people, and then see which ICD-9 codes you actually impact. And we haven't done enough building the penultimate model. So, just doing regression modeling on a historic data set it's telling you some patterns in the data, but it's not really telling you what's possible. And when I look at what's ambulatory care sensitive, I think there are a lot of things that aren't on the list that are also ambulatory sensitive that are missing. And the only way to do that experiment right would be to spend a whole lot of money to build the perfect model and then look back and see, what difference it made and which codes it made.
Perhaps you could make some informed, instead of doing that, could you make some informed guesses about what sensitive conditions may be in addition to the ones that are on those lists?
I think every single code is ambulatory sensitive. I think a hospital admission is a failure to preventabilize. If I gave you infinite money, time, and a lab to figure it out, there's almost everything you could move out. If you really built the penultimate system that was really wonderful feedback loops, had highly talented people, you were allowed to, break things and try new things, I think you could drain the hospital out completely. There are very few things that need to be in a hospital, really. The end of life doesn't need to be there. That gets rid of half the ICU, right? The only people that need to be in ICU are younger people who can recover. Birth shouldn't be in a hospital. High-risk births should be in hospital. Heart attacks shouldn't have happened. If you were getting all the preventive care, you probably wouldn't be there. There's a lot of stuff that's preventable that we're not even scratching the surface. The big play on this right now is Bravo Health in Philly has hired the best hospitalist in the region. They're a Medicare Advantage plan. They set up 2 primary care offices in Philly, and they're playing this out, and they're making a mint. They got bought by HealthSpring and then by Cigna, purely playing this game.
Can you discuss the depth of knowledge for the team that you've built and why that's impacted your results?
Great question. So we've done a lot of training with our team and a lot of thinking about roles and responsibilities on the team. And I would throw a huge bone to our friends over in addiction and behavioral health and in geriatrics, because they're way, way, way ahead of the rest of the medical profession. So we have wildly borrowed ideas from PACE, Program for All-Inclusive Care for the Elderly, from ACT, Assertive Community Treatment, from Ryan White Clinics, from Nurse Family Partnership. No one is out of sight, out of mind in our intervention. Every morning we huddle and we do team report and run the list of everyone. We've trained everyone in motivational interviewing, which is a style of communication borrowed out of addiction and behavioral health to help patients set goals. One of the things we've noticed is that poverty work attracts some very emotionally unhealthy people. So we've had to get a lot better about who we hire and then a lot clearer about who we keep and what behaviors we're expecting. We've also had to make the intervention much more structured. So we didn't not have a graduation point. Now every staff has a Samsung pad in the field, and we collect about 140 data points on every patient. It's a very structured intervention. In business terms, what we've created is called a focused factory with very clear roles, responsibilities, delegation, data collection, benchmarking, so that I've got high fidelity and I know kind of what everyone's doing every day. And then that requires a tremendous amount of mentoring and team training as well. So doing a lot of training with our staff. Not everyone can do this work. It's very hard, challenging work.
Hi, I want to thank you for your talk. Very, very inspiring. You mentioned that you thought one of the only ways to change everything is to get a new generation of colleagues. So aside from you going out and handpicking the next generation of physicians, how do you suggest that we make that change?
So we're working with the AAMC, which is the Trade Association of Med Schools, and we've created a 10 easy steps to hotspotting, which is really an educational project where we're encouraging faculty to work with students. And this is really a form of root cause analysis, and it's classic technique in quality improvement to go out and find one extreme case of failure and pull it apart. So it's essentially a guide on how to do root cause analysis in care coordination, going and finding one patient and pull the story apart. So I think there are a lot of agents of change in medicine, both faculty, attendings, residents, students, and I think we need to find them and empower them with stories and help them learn how to find the stories and tell the stories. So it's really a storytelling project. We're giving them a media release, and it's not a research project, a media release and a medical release form. And with the medical release form, you can actually get people's medical billing data. So, short of getting the whole city's hospital data, you can actually have a patient sign a release form and go to the medical records department of every hospital in the region and get their individual claims data. So it's a technique for educating students on how to solve this. A lot of this problem is realizing what the problem is, and you don't realize what the problem is until you've started doing this kind of root cause analysis. So that's one of my hopes. I was just on a webinar with and spoke at the AMC conference to try and get students doing this. So if any of you are med students in the room, what we've encouraged them to do is to build cross-functional teams. Public health students, nursing student, med student, social work student, and go out and do some root cause analysis, go out and find these cases. On March 19th, we're going to have a second annual Superutilizer Conference here in Philly. In the evening, there'll be a poster presentation. Each poster is a single case. So it's a picture of the patient, their claims data, just like I showed you here, some system-based learning. And we're going to give a prize to the 3 groups of students who find us the most interesting cases. So any of the students here, go find your med school colleagues and form a team and find some cases. There's very detailed directions on how to do this on the AAMC website and our website.
So I guess my question is, are there any hospitals that are leading this charge in your terms, and what are they doing to prepare?
Yeah, it's really Midwest hospitals. It's hospitals in the middle of nowhere. I think Geisinger's doing interesting work. The most advanced healthcare system in the country is the NUCA system in South Central Alaska. It's 3 tribes that were fighting with one another that came together, took over the Indian Health Service, and they run the hospital, the secondary care, and the primary care for a 1,000-mile region. And the stuff they're doing is so far ahead of us. They have like a team of 50 process improvement engineers. Their primary care model, the doctor's not in charge. It's a flat team-based structure with a psychologist, with health coaches, social workers, primary care provider, but it's a flat team-based model. So stuff they're doing is just light years ahead of what we've been able to do. Half their total payment is a global payment. So really what we need to move to is defined populations in a defined geography, I think, with global payment and intermediary structures that force collaboration between the stakeholders, which is kind of where we were headed back in the 70s. So this is like just doing what public health was trying to do back in the 70s.
Have you found that that you have a patient that's in the ED, they're thinking about admitting, that those providers are now going to the data warehouse and saying, wait a minute, how many times have we scanned this guy?
Yep.
Are they using the data?
No, they're not.
So that's also somewhat of a shift
Yep.
in providers' mind to say, wait, we have this data. Let's look at it.
So how many years I've heard emergency room and hospital docs complain like, oh, we can't get access to data, so we turned the damn switch on 3 years ago. Beat our head against the wall, raised all the money, got it going, and no one's logging in. And then we go train them, and we have a few early adopters who are younger, who are like all over the system and logging in all the time. So what we found is that we actually had to go in and re-engineer their workflow and reconfigure how everyone did everything, assign it to someone specifically that was delegated work. And it really points out that health IT is not going to fix broken people problems. And so much of this is broken job descriptions, roles, responsibilities, workflows. These are business problems. These are business failures. And we're going to need some really smart systems engineers and business MBAs to come in and fix the mess.
Sorry about the delay. Thank you. My question is, what is the future looking like for Camden, and do you think that this tertiary prevention is going to help out with the many other issues that Camden has?
One of the things I've died on the mountain too many times in Camden of trying to fix too many things. So I can't cure poverty. I can't fix housing. I can't fix the collapsing sewers. The trichloroethylene in the water this week, I can't fix that. I can't fix most things, but I can make sure that every hospitalized patient gets caught by a well-run primary care office. And if I fix that, it's one less burden on people who are poor. So poverty is not just the lack of money. It's the overwhelming sense that you don't control everything, anything at all, and that nothing works. The police department doesn't work, the school district doesn't work, the streets are collapsing, the water's not clean, the air's not clean. It's this overwhelming sense that none of the rules are fair in society. And, there was a point at which it wasn't so bad to be poor in America, I think, when city services worked, and what was good for the middle class was good for the upper class, was good for the poor. And we're to the point now where we have segmented out all of demography so that if you drive from downtown Camden to Haddonfield, every streetlight is $5,000 difference in annual family income. So we've done perfect segmentation by income. And I think, the time that Camden ran well was when, the upper classes and middle classes benefited from well-run police department, well-run schools, and all these things. So I'm going to just focus on making a well-run healthcare system, because I think when you get treated badly by your doctor's office, it's really disempowering. When pregnant moms get treated rudely and can't get an appointment, it's really disempowering. Thank you. It's a great way to
Thank you very much, Dr. Brenner.